Hello, and welcome to another edition of My Health Matters. I am Shay Brown, family nurse practitioner, plant-based nutritionist, personal trainer, and obesity management specialist. I have here with us today Dawn Johnson-Leonard. She is a breast cancer surgeon. She is the chief surgeon at the breast cancer surgery at the Christiana Care Medical Center system in Delaware. And we also have with us today Rhonda Silva. Rhonda Silva, I've been knowing Rhonda for a few years here. She has been a wonderful advocate at the University of Maryland Breast Cancer Center. She has been an advocate promoting free breast exams at the University Center. We are going to have these ladies pretty much introduce themselves because I'm like fumbling all over their words, but I believe that they can give a better introduction than I can. So we're going to start with Dr. Leonard. She's going to introduce herself and give you guys all of her credentials, okay? Go ahead, Dr.
Leonard. So as Dr. Brown has said, my name is Dawn Leonard. I am a breast surgical oncologist. I specialize in treating benign and malignant breast disease, and that is a pathway that we reach through training in general surgery and additional fellowship training in breast surgical oncology. So although in my new life here in Delaware, the majority of what I see is treating breast cancer, in my private practice years ago, it was all aspects of breast disease.
Excellent, excellent. And we also have with us today Ms. Rhonda Silva. Rhonda, if you want to introduce yourself to everyone today, please.
Hi, everyone. My name is Rhonda Silva, and I'm the Division Administrator / Program Manager of the Baltimore City Cancer Program at the University of Maryland Greenbaum Comprehensive Cancer Center. I know that's a mouthful. I have been the administrator for 20 years. It'll be 21 years in December. We're a grant-funded program. We do screenings for breast, cervical, and colorectal cancer. We also have diagnostic and treatment services. Through the grant funds, we look for women and men who are uninsured or underinsured and are 250% at or below the federal poverty. So I'll be talking more about that as we continue on today.
And that is something that we definitely want to get more involved with because we want everyone to be screened. And we want everyone to put that health first. So as we get into our segment today on breast cancer, we want to talk about how breast cancer has been affecting a lot of our community today. Dr. Leonard, do you want to touch base on the different types of community involvement that affects breast cancer today?
So when we think about breast cancer, we think we'll talk about the U.S. because what happens in the U.S. is more closely reminiscent of the European model. What's happening in African continents is a whole different matter that really makes treatment, diagnosis, and access so much more vital. So here in the U.S., we anticipate that we're going to diagnose about 379,000 women this year with breast cancer. Of those women, about 2/3 of all of them will be diagnosed with an invasive breast cancer, which is a form of cancer that has the ability to spread or metastasize to lymph nodes or distant organs. About 1/3 of patients will be diagnosed with non-invasive cancer, which is just in the breast itself, but left untreated, between 40 and 60% of those can convert to the spreading kind of cancer. So there's no breast cancer that's unimportant. About 1 to 2% of those cancer diagnoses will be men, about 2,000 to 3,000 men each year. So they don't make up the majority of patients who were diagnosed. In the past, breast cancer was really thought of as a disease that did not occur as frequently in women of color. The incidence was higher in Caucasian women. But in the last 15 years, we've noticed by looking at data that the incidence rates among African American women are now equal to the incidence rates in white women. Your risk on average is about 1 in 8 of being diagnosed with a breast cancer. That's about 12% lifetime risk. The sad thing about breast cancer in our populations, and I consider myself part of that population and I'm of age, is that in Black women, the incidence of breast cancer is actually higher in Black women under the age of 50 than it is in other populations. We have a higher incidence of diagnosis under the age of 50 and especially under the age of 45. And in that population, the actual cancer diagnosis is more aggressive. We have more aggressive forms of breast cancer that grow faster, that metastasize or spread at smaller sizes, that have characteristics of the cancer that make it more difficult to treat. You'll often hear us talk about something called triple negative breast cancer. It doesn't respond to hormonal influences, and it does not overexpress certain proteins, where the only treatments are surgery, radiation, and chemotherapy, but they're very, very aggressive. And the survival rates amongst women of color of all ages is lower than the survival rates of white women. Over the last 20 years, we've seen improved and increased survival rates in non-Black populations, but we haven't seen that reflected as well in African American populations. And that's for a myriad of reasons.
So when would you suggest, or what would you recommend for people to start getting screened for breast cancer?
So in my community and in my field, we follow what's called the National Comprehensive Network Guidelines and the American College of Surgeons and American Society of Breast Surgeon Guidelines. And those guidelines recommend that for women of average risk, they should start with annual screening at age 40. There are a lot of different guidelines out there that recommend other screening modalities, some of which recommend starting to screen at age 50 and doing it every other year. That's problematic for us in the cancer community.
Okay.
Of those 300,000 women, about 100,000 women are going to be diagnosed before the age of 50. So if we're not screening before the age of 50, we're losing an opportunity for early diagnosis. Some of those guidelines also recommend that we stop screening women at the age of 75. Well, guess what? 60 to 70,000 women a year are diagnosed after the age of 75 and have a life expectancy well into their 80s. So if we don't screen patients before they're 50 and we stop at 75, over half of all diagnoses will not be diagnosed early or will be diagnosed late. And in my mind, we're treating those people like they're disposable. There are no disposable people here.
Right.
So age 40 is the age, annually is the age, and screening should continue until quality of life suggests that it's time to stop. Not a particular number, quality of life.
So when you say not a particular number, this number, where does this number come from? Insurance companies?
Well, I think some of the data and the science out there is looking at life expectancy, the types of cancers that are diagnosed in older women, and without certain science to back it up, they say, well, after age 75, life expectancy is so limited, will treatment benefit be worth that amount of time? That's a number. That's not a person. And how can you tell somebody that any amount of time that they have quality of life is not valuable based on a certain age? My oldest patient I ever operated on and diagnosed, she was 99 years old. And when I left clinical practice in that area, she was 104.
I mean, we know 86 years old, Ernestine Shepherd, and she just ran the when in the marathon this past weekend. I mean, she ranked #1 in her age division. I mean,
Yeah.
she ranked what? She was in first place in her age division. I mean, she ran like 6 miles. So, I mean, you want to tell her that she can get screened for breast cancer?
Exactly.
She's living her best life.
And the truth is, the theoretical harms of screening that are listed as reasons to avoid screening mammograms do not have anything to do with radiation toxicity, because that has been documented to be a fallacy with a mammogram. These are low dose studies, low dose x-rays that have less radiation than in a chest x-ray or a dental x-ray. There's not a risk of tissue damage or harm from compression. Oh, you're going to hurt me. Ouch, ouch, ouch. They're crushing something. They're spreading. No. The theoretical risk of mammograms is anxiety. That is what's listed. Oh, women become more anxious if we screen too early or continue screening too late. And I think we're a whole lot more resilient than that to use anxiety over getting a mammogram as a reason that we shouldn't recommend it for the entire population.
Most people don't like that little machine squishing their tatas.
Once a year. Mm.
Yeah, less
all
than
we
30
ask.
seconds.
We
I mean,
ask one day of the year to take what, 15 minutes to do that exam. Come on.
yes. And I mean, you just don't know what life, your life, to be saving, you know?
My
Absolutely.
life is worth 30 seconds.
Mine
You
is
know,
too.
hey,
Yeah,
we don't
absolutely.
have sympathy. If you got multiple piercings, you got earrings, you got a tattoo, you had a baby, you had other exams, your teeth cleaned, or other exams we don't like so much.
Teeth pulled.
There you go.
Absolutely.
That's more torturous than that mammogram.
Right.
Rhonda Silva, can you tell us about the program that you guys have for people that, you know, may not have the insurance to get the mammograms that would like to be proactive about their health?
So since August of 21 years ago, when the program began, we were given grant funds through the Cigarette Restitution Fund. Also, we have been given grant funds through Komen and Avon, but the main grant, which was the Cigarette Restitution Fund, was to go to the underserved communities in Baltimore City. This is where we started at, and look for women and men who were uninsured or underinsured. And what we began to do was to go into the community and begin to educate. We were able to partner with FQACs on the community, churches, organizations that even had back to school nights. We began to make ourselves known in the various underserved communities by giving out flyers, coming to events, and hosting events to give out the most important information that we felt would get to so many people who needed this service. And so in 2001, we began screening women who fit the eligibility criteria at no cost to them. We delivered a clinical breast exam, a pap exam if you had cervix, because we were looking for cancer in the cervix. Once you had that clinical breast exam and that cervical exam, then you went on to a mammogram. We paid for that as well. And if you needed transportation to get to that mammogram, and what we did was we hooked up with outside entities. We knew that it was much more important to have advanced and American radiology contracts so that we can meet you where you live in your community, so that you didn't have to travel that far. And so it would be no excuse that you could tell me I can't get there. Wait a minute. So we also have patient navigators, nurse case managers. So what happens is, if there's an abnormal finding, we're not going to let you go. We're going to walk with you through the medical continuum. We're going to walk you right down to the Greenbaum Comprehensive Cancer Center. And whatever biopsy, surgery that is required, diagnostic and treatment wise, we're going to begin to walk with you through that and also pay for some of that. Now, Maryland Diagnostic and Treatment Services is available for breast and cervical through the state of Maryland. So when we see that our funds are being eaten up a little bit too quickly, we will register that patient for the Diagnostic and Treatment Services of Maryland. However, that patient stays at university and continues to be a part of the multidiscipline team that's downtown. So chemo, radiation, all of those things are going to be taken care of as you come through my program.
We have a question for you, Dr. Leonard. Ms. Cochran, Janai Cochran asks, can breast cancer cells can travel throughout the body? Can they travel throughout the body?
So the answer to that is yes. That is part of the harm of what we call an invasive breast cancer.
Yes.
There are a lot of different individualized cancer cell features that allows a given cancer cell to do that. So every cancer cell in an invasive cancer doesn't have the ability to travel, but every cell in invasive cancer is different. Each time it divides, it evolves a little bit more. So breast cancer cells do have the ability to travel throughout the body. They typically will start in the breast and then gain access to the lymphatic system or our lymph node system. And the lymphatic system dumps into the circulatory system, and they will circulate throughout the body. And those cells that have evolved to the point that they can be sticky again to stick to another structure will then start dividing in that structure. And we call that metastasis.
Mm-hmm.
So that is one of the reasons when we treat invasive breast cancers, we treat not just the local area, the breast and the lymph nodes. We think about medications to treat the body as a whole, to be able to kill any of those circulating cells that is trying to float until they can set up shop somewhere else.
Absolutely. So, do you encourage patients to do self-breast exams?
I do.
I do.
So we do. One of the things that is consistent across the guidelines for breast cancer screening is that we tell women you should be familiar with how your breasts look and feel.
Right.
And how are you supposed to know how your breasts look and feel if you're not doing self-examinations? You can't report problems if you're not checking and you're not familiar with what's normal for you. And a great opportunity to learn how to do that or to learn what's normal for you is to have that conversation at the time of your annual checkup with your provider if you have a normal checkup. So I and us, we in my field, all of us, we do still encourage self-exams.
Okay.
I'm not going to lie and tell you that self-examinations change survival rates. But how are you supposed to report a problem if you have no idea what it feels like or what it normally looks like?
Absolutely.
And we want you ladies to be proactive. We want you to know your body, even if you have to stand in a mirror after you've taken a shower and look at both of your breasts. Don't feel afraid to touch them, because if you found a lump and you're waiting 1 year, we don't want that.
Right.
Early detection saves lives. And that's what we want you to do. And also we want you to ask your relatives, your female relatives, aunts and grandmothers and moms, do I have breast cancer in the family? Or find out about your history, not just breast, cervical, colorectal, any kind of cancer. Ask.
Why is that such a hush thing? I mean, in the office, when you ask the patients, do you know if your relatives have any history of any cancer? I don't know. I mean, when you have a patient that tells you that I don't know if I have a relative that has any breast cancer or any type of cancer, I mean, what are your recommendations on the screening process at that point? Because that's kind of tricky. I mean, what if they do have a family member that has a history of breast cancer? I mean, do you push the screenings up to 35? I mean, what do you do?
Well, it depends on the history. One of the main reasons that we don't know history, one is because elders keep secrets. They don't tell anybody nothing about nothing, and they are so proud of taking it to the grave. But the other reason that we don't know a lot about history is before the modern era, a breast cancer diagnosis was a lethal diagnosis. It was a death sentence. So it was whispered about because it was very frightening. And they didn't have the ability to have the science that we do now to have a better understanding of not only why breast cancers happen, but tools to prevent it from happening.
Right.
So in the past, and many people who have a family history of breast cancer, their mothers, their grandmothers, what they remember is suffering and eventual death. That is what their familial memory is, and that's traumatic. What they don't know is that now our expectation when we see breast cancer patients, we expect cure and survival for the majority of our patients. There
Mhm.
are almost 4 million women living in this country today who are breast cancer survivors. We have more
Yes.
breast cancer survivors than any other cancer type other than skin cancer. So part of it is educating to release the stigma and getting people to understand the importance of family history and how it impacts screening recommendations. For us, it's not just our family history of hypertension and diabetes and heart attack and stroke as a familial legacy. It's also our cancer history because all of those things we approach differently from the preventative spectrum.
And
Absolutely.
And as we at Baltimore City Cancer Program, we're going out into the communities, we begin to talk about that. That is our main pitch. That we want to talk to you about the history that your family has. And that if you come into our program, get a screening and find an abnormality, that talk continues downtown.
Mhm.
Downtown, that multi-D team will begin to ask you questions because they want to know, do you need genetic counseling or do you need genetic testing? So that
Yeah.
we can find out, is there a gene that could possibly be there that is that it's hooked in your hereditary timeline? So we really, really encourage our ladies and men to begin to ask those questions.
Now, another question that I have for you. Now, the different stages. Now, a lot of people, they, for lack of a better word, start freaking out when they hear the word breast cancer. All right, what stage am I in?
Yes.
Um, they don't know the stages. Well, it's stage one, stage two. If it's stage four, it's doomed. I mean, what are the stages? I mean, when should people start to worry? Is there any hope at stage four? At stage one, I mean, should they worry at that stage? I mean, let's talk about the different stages so people get like a general idea of the different stages of breast cancer.
So stages of breast cancer 1 through 4, and regardless of stage of diagnosis, we have hope and we have treatment. Period. That's the main thing to walk into the door. It's not so much an understanding that, hey, I've got this and I'm terrified. It's an understanding that no matter where you are on that spectrum, we have options, we have hope, we have treatments. Even if you decide you don't want to have anything done, we will still be in your corner to help you advocate for what is right for you.
Mhm.
Stage 4 breast cancer is what we consider a distant metastasis to an outside organ other than the breast and the local lymph nodes. Stage 4 breast cancer is not considered curable because we can't eradicate it from every place in the body.
Right.
But we have treatments that can prolong life significantly. It's just that those treatments are lifelong treatments at that point in time. And we have more than just one treatment. We have first line, second line, third line, fourth line, as well as the mighty clinical trial.
Mhm.
More women of color need to participate in clinical trials.
Mhm.
How do we know what is effective in our population if we don't study our population?
That's right.
Well,
And this is not experimentation.
but our population are a little skeptical about
Absolutely.
experimentation because we have been used as
Absolutely.
in the past. So we are not that, as I'm not saying me, but I'm just saying as my community speaking,
That's right.
we're
Yes.
not so much forthright as letting people experiment on us
Right.
anymore because
And
our
those,
history.
yeah, those historical clinical experiments, because we're not going to call those clinical trials because that's not what they were.
They
Right.
were
Those atrocities, because those are considered medical atrocities. Okay,
Yes.
what was happening at a certain illustrious institution in Baltimore less than 100 years ago, what was happening in Tuskegee, what was happening in Mississippi, what was happening in certain incarcerated people here in Philadelphia. Those are medical atrocities. That is not medical research in the classic sense. But those medical atrocities laid the foundation and the groundwork for how all clinical trials across the board must be performed.
Yes.
First, do no harm. There must be a respect for autonomy. There must be a respect for the patient having full information about the risk and benefits and use of the materials that they are participating in. And there must be full transparency.
Absolutely.
The truth is, if those things cannot be demonstrated, that is not a legitimate clinical trial through an appropriate agency. We have the National Cancer Institute, we have the Alliance. There are a number of organizations that have come together to govern clinical trials, and there has to be usefulness. And those trials have to be assessed periodically to make sure that there is no harm being done. If harm is being done, they are stopped. And the flip side to that coin is if they see significant success, the trials can be stopped to promote new treatments so more patients can get those treatments. But in Baltimore in particular, I practiced in Washington, D.C., in Maryland, and in Baltimore and in Frederick, Maryland before I came to Delaware. And there is a mistrust of the medical community in areas where those medical atrocities occurred. And it was an earned mistrust. But one thing we do know, if you are diagnosed with a breast cancer or a cancer in general, patients who are treated at comprehensive cancer centers have better outcomes. So seeking care at comprehensive cancer centers, either community-based or university-based. I'm sorry, I forgot my words for a second. University-based, that makes a difference. And being treated by what we call a multidisciplinary team, where you have a team of specialists who is treating your disease process, your surgeon, your medical oncologist, your radiation oncologist, your nurse navigators, your geneticist, your support and allied health people with physical therapy, being treated by a multidisciplinary team that communicates and talks about each case in a transparent and open fashion. It ensures, or it's a better assurance. I'm not going to say it ensures. It provides a better assurance that each patient is being treated as an individual, and it reduces disparities that are associated with healthcare bias.
And on that note, the University of Maryland Greenbaum Comprehensive Center, we offer all of that.
They do. I mean, they do.
All you do is come on in. We don't charge you, no cost to you. Just come on in. We'll take care of you. All them team, that multi-team approach, we got that too.
Right.
Well, yeah. Miss Silva, one thing is, I don't know if you all picked up. I participated in BCCP and D&T when I was in Maryland. And it is one of the most wonderful programs for patients who are underserved and need this care.
That's why I met you at.
That's right. BCCP is for screening. But if a woman comes in and is screened and found to have an abnormality that needs additional work, they flip them over into the diagnosis and treatment program to ensure that there are no delays in their diagnostic workup and no delays in their treatment. They are reducing those disparities by ensuring access to people who have the least amount of access and feel like they have the least amount of autonomy and identity in the process. It is a program that absolutely works.
Yes, it does. And it has over the last 20 years because BCCP is all over Maryland.
Yep.
We have another question. How can we bring more awareness to the Black communities? I think both of you can answer that question.
I think through community events. I mean, we have been into so many communities of the underserved over the 21 years. We have educated over 38,000 women and men, telling them about the importance of screening and telling and educating them about how also important early detection saves lives, along with health, walking, exercise, food. All of that is included in what we do in the communities.
We have to meet people where they are. That's why we speak on podcasts. That's why we go to barbershops. That's why we're in hair salons. That's why we're in churches. You
Yes,
must meet people where they are. But we also need to have more representation in our educators. It's
yes,
very difficult to go into a community where you don't look like someone, sound like someone, understand their experiences, or understand their genetic and
yes,
societal history. So
yes,
we need better representation in healthcare, just like we need better representation everywhere else. And we need informed advocates. The most wonderful thing we see is a patient advocate who is informed. The most harmful thing we see is a patient advocate who don't know nothing about nothing, but feels like they know something about everything.
Absolutely. Absolutely.
mm-hmm.
We have a guest today, a person of the public. Alice, let's see. Alice, can you hear us on the show today?
I can hear you. I'm not sure if you guys can hear me.
Oh,
Yes,
okay. Because we can hear. I have you on, but I'm like we cannot see you clearly. So I kind of
Right.
took you.
Scrambled.
Yeah, it kind of like took you off. But if you are okay with that, can you just tell us a little bit about yourself? You are our person of the public. We have Dr. Leonard here. She is a breast cancer surgeon, and we also have Rhonda Silva. She is one of our advocates for the Breast Cancer Society. And you know me, Shay Brown. You know who I am. But can you introduce yourself and tell everyone about you and your experiences with breast cancer?
Okay. My name is Alice Lipsy, and I'm a 14-year breast cancer survivor and a 30-year leukemia survivor. And I've had the pleasure of meeting Dawn, and also I'm in the Living Loving Breast Cancer Survivor organization as well, along with the TJC organization. The journey continues, and as I just piggyback on everything that was already said, I just thank God. The most important thing is, of course, is faith. When you're going through and when you get the big C, most people immediately think cancer, death, that it comes immediately. But if you have faith and if you have a good support system, that makes all the difference. Having, whether it be even a good friend, it doesn't even always have to be immediate family, but just having a good friend that has your back, that will encourage you and that will support you and help you. That is, I mean, if you have those two things, the battle is pretty much won with that. So I thank God that, I was blessed. There are a lot of women that don't have such a good support system, but that's where we come in at. There are different organizations where we take people to their appointments, where we make bags and of toiletries and different things that they may need. If they need us to come and clean up or do something for them, that's when the different organizations come into place. And so that's very helpful, being connected to an organization or support. So I mean, I've been fortunate. The doctors that I've had my surgeries at both my surgeries at University of Maryland, and I've been fortunate to have great doctors, great nurses, and people surrounding me, which also makes a big difference. Your surgeons, you have to not just go to your appointments, but sit down and have a personal conversation, because I've had to sit down with my surgeon, and she wasn't very friendly or very personable.
Mm.
So I said, I don't want someone cutting on me and you looking at me
Good
like
for
I'm just
you.
a piece of meat.
Good for you.
Good.
So I had to sit, I prayed about it, and I told my husband, I said, I'm going to have a conversation. And I thank God I prayed and asked the Lord to open her heart that she could receive me. What I was saying, I was just letting her know, you don't have to hug me and kiss me, but you have to be a little more personable with me.
Yeah.
I'm a patient, and I don't want to, feel like I'm feeling and I'm getting ready to get cut and go under the knife, and you're going to be the one doing it. So she said she didn't realize that she was actually doing that. So I thank God for that. And she said she would work on that. She said, I didn't realize that. But it's like they see so many, some of them, not all of them, they see so many patients, and it's like they just constantly moving, and they don't take the time sometimes to get a little more personal, So I thank God that just get to know your team, because you're gonna have a team when you go through something like that. And that's important, to have a great team around you, and don't feel like you can't ask questions. You can ask questions and be prepared with your questions, because the doctors and nurses don't have a lot of time. So, write your questions down. Let them know how you feeling. And, I just think that's so important. You have to be self-motivating, and you have to be, of course, like everyone said, proactive in your own health. It's your health.
It's your health.
So, um, I can give a testimony, but I know we don't have that kind of time. So, yes, I'm so grateful. And, even when I was diagnosed with leukemia 30 years ago, I didn't know anything about that. I just thought Jerry's little bald head white kids on Jerry's telethon.
Right.
That's all I knew. I saw the leukemia patients, and then as time went on, you started hearing about, different people. And of course, as the one person that most people know, B. Gaddy. And the problem with that is, as nurturers, as women, we are just ordinary, regular nurturers. She did not nurture herself. She took all this time to nurture everyone else, but she didn't take care of herself, and she didn't go, it was like, oh, I'll go later. And again, I think the doctor said something about that older generation. They think, oh, I'll do it later. I'll go later. I'll do this. I'll do that. But yeah, she's feeding the public. She's doing everything for everybody else. So that's also important. We just have a natural nurturing spirit.
So your process that you went through was a pretty smooth process for you.
Yes, and I tell everybody, you cannot go by somebody else's experience as far as pain, because some people say, oh, I had so much pain, I that. Everybody don't experience. You may have the same surgery, but everybody don't experience it the same. You know what I mean? You may have some symptoms that I didn't have. I may have some symptoms that you didn't have. So, you can't go by that. You just have to stand and pray about it and ask God to give you the strength to get through it. And don't compare. Just know and have faith and trust that, this is your path, this is your journey, and this is your process. And you have to walk through it.
Absolutely.
Great.
So, Alice, when you were diagnosed with breast cancer, what stage were you?
I was stage 2.
Stage 2, okay.
Yes.
When did you undergo chemo or radiation?
I did now, and here's the funny part. No, well, not funny. Here's what I think. I heard a lot of the stuff where the anxiety comes in when you go get a mammogram, and this is years ago. When you get a mammogram and you hear the horror stories, and then even if you have someone that I've had, the one before I was diagnosed, the year before I was diagnosed, I had a nurse who was very hard. I mean, when I left out of there, my boobs were black and blue. So I was like, I ain't going back. And that was in my head, because I was like, oh, that was terrible. And you know, the funny thing, I didn't go back that next year, but when I went back the following year, that's when I had the well, I was proactive. I felt my own lump in the shower. So I definitely agree. Please be proactive. Please do your self mammograms, because I did find my own. But I'm just talking about a bad experience that didn't let me go every year like I was supposed to go. You know, that one bad person, or not person, experience that I had, I was like, I'm not going back. So I did find it myself. So that's important. And my experience, like I said, once I went through, I had to have chemotherapy. And I had gone through chemo before, so I was a little bit familiar with it. But of course, technology had grown and things were different and things was much easier. And each year, that was 14 years ago. So now, I mean, it's tremendous. The technology is just awesome right now. So don't be discouraged, even if you have one bad experience and somebody smash your boobs a little too hard. Go back. The next one won't be that bad.
Right.
Or go to a different one.
Go to a different one. Absolutely. Or make sure you can see her name and say, I don't want Susan, or I don't.
I know, right?
You can request your own person.
There you go.
We have another question. To clear up a myth, is it true that women with small breasts can't get breast cancer, Dr. Leonard?
Absolutely not.
That
you
is
can be an A- to a B+. You absolutely, the amount of breast tissue you have does not impact the risk of getting breast cancer. Less is not better, more is not worse.
Right.
Men have breast tissue as well. They get breast cancer, and most men don't have breasts as large as most women, although there are some men out there who are rocking some C cups. So yeah. Yes, that is absolutely a myth. If you have breast tissue, you have a risk of breast cancer. And there are techniques to screen women of all sizes. Even women who are very, very small breasted or flat chested can still get a mammogram. And you want to get them because even if your breast is small, you still want any problems detected before you can feel it or before it's palpable.
Right.
And we've seen two men throughout our 21-year journey, too. And their breasts they didn't have, yeah. There you go, Dr. Leonard.
Yeah. I mean, again, this is all we do here. So we have, we get a cluster. We're on our third cluster this year. So up here, Delaware is a weird state. We have a lot of breast cancer for a very small state. We actually have the highest number of triple negative breast cancers diagnosed in the country here. We don't know why. We have thoughts about why, but we ain't allowed to say. So our first cluster was January. There were 5. We had a second cluster in about June. There were 4 or 5. We just got our third cluster of 2 or 3. So it happens. I don't know why we're seeing so many here.
Look,
but most of us will see 1 or 2 a year.
We have 3 so far since July, and 1 biopsy coming down the pipe. So I get it.
Yeah. See it.
As we were listening to Alice talk about, the amount of support that she had, I mean, I think that was absolutely wonderful. Whenever someone has something as traumatic as cancer to be involved into their life, I mean, having that support is so important. It's beautiful that she did have that support, but what if a person doesn't have support like that? I mean, is there any type of groups that they could go to get, support like that? Like, well, not like what Alice was getting, but are there any type of support groups that people can turn to?
I want to just briefly talk about the support. We have found women who have not had anyone to go with them down to multi-D or to go with them to surgery. And my community outreach workers do that. If there's no one who's going with you to surgery and you're by yourself, we're going to meet you down there. If it's 6:30 in the morning, we're going to be down there for you. But we do have 2 support groups. One is Living and Loving Life, that is run by LaVesta Jackson recruit. And our second one is a Latino Spanish support group. We found that it was very difficult for some of our Hispanic ladies to understand everything that our English speaking ladies were talking about. So we felt as though we needed to kind of separate that group, and it is going wonderful. So the telephone number is on the screen. If anyone's interested, we welcome all. You do not have to be diagnosed through University of Maryland or through the Baltimore City Cancer Program. We welcome anyone who's willing to come.
Excellent, excellent, excellent. Thank you so much for that. And we have another question here. As I get older, do I still need a mammogram after the age of 70? I don't think they heard you answer that question.
Yes. Yes. We live long, ladies. We're living in our 90s.
So some people are using their senior card and they don't look like seniors.
Absolutely. But you've got to keep on going with these screening mammograms. It's very important, ladies. So yes, we will screen you after 70.
Another question, why is breast cancer so high in Black women compared to white women? That's an excellent question.
That is also a myth. The incidence rates in Black women and white women over the age of 50 is identical. So it is not higher in Black women over the age of 50, it's the same. Under the age of 50, especially under the age of 45, the incidence rates are higher in Black women. And we don't know why. It's a combination of factors, and most likely it's a combination of genetic factors. So let me give you some global facts to put this in a little bit of a different light. If we look at the women living in African nations, Nigeria, Ghana, Kenya, although the incidence rate of breast cancer is lower in those countries, I'm going to take Nigeria as an example. 30,000 Nigerian women will be diagnosed with breast cancer this year. One of the differences in African populations to American populations is the average age of a breast cancer diagnosis in Africa is 48 years old. It's under the age of 50. Mm-hmm. And 80% of the women who are diagnosed in those countries are actually diagnosed with late stage disease, stage 3 and stage 4 disease, because of access issues and because of cost issues. They're not being screened, they're not being educated, and they are not, they don't have access to treatment. And what that translates into is the 5-year survival rate in those stage 3 and 4 patients is 10%. Mm-hmm. Amongst all comers, the 5-year survival rate in African nations is 35%. The 5-year survival rate in the United States is 85% or greater, depending on stage. It's a flip in numbers. Mm-hmm. One of the differences between the African American population and the African population is we get the best of all worlds. We have the influence of the genes of our African ancestors, but we also have the influence of the genes of our non-African ancestors because we are the children of slaves. Mm-hmm. So we get a bimodal distribution of breast cancer. We get the early and we get the late because we do have those genetic influences at play. Now, that doesn't take into account the environmental influences, which there are a myriad of: diet, exercise, health, water, food, stress. It doesn't take into account the familial and genetic risk factors as well. Mm-hmm. So it's so multifactorial. But one of the reasons that I believe that we have this bimodal distribution in Black African American women is that we reflect the genetic history of all of our ancestry, which is both African and European. This is also an active area of study. The cancers that our young Black women get are closely reflect the cancers that are seen in African women, triple negative aggressive breast cancers. That's more normal or more the norm in African population. So the overall incidence in Black American women is identical to white American women. It's just we get worse disease, higher stages at diagnosis, less access to screening and treatments, and poorer survival. So it's a slightly different twist on that why question.
Absolutely. So, another question, what is the screening recommendations for people post breast cancer?
So that's a great question. So they are a little more normalized. Post breast cancer, the screening is actually very similar to pre breast cancer. The new recommendations coming out of the American College of Radiology, which are being more standardized, is you should continue your annual mammograms. The first one or two are most likely to be a diagnostic study that is read at the time the study is done versus a screening study, which is read later. Once that study normalizes, going back to annual screenings is recommended. We don't recommend that you stop, and we don't recommend that you skip years. The use of advanced studies such as MRI is patient dependent. Some patients who have cancers that were not detected on mammography and only detected on an advanced study such as an MRI may need to continue those studies in addition to mammogram as well. And then ultrasound is not a screening study, that's a diagnostic study that is targeted towards an area of abnormality. So just a screening whole breast ultrasound is not encouraged at this point in time, because like any other technique that's in somebody's hands, you'll have miss areas. And when we say miss areas, I want you to think about if you ever painted a wall or painted a picture and you think you covered that whole area, but when it dried, you saw thin spots that you didn't hit quite as well. The same thing happens with ultrasound if you don't have a target to go towards.
All right. So another question that I do have with men that have breast cancer, is that mostly genetics, or it doesn't have to be genetics? But what do you find? Do you find that it's mostly genetics?
That is true. So most men with diagnosed with breast cancer
just
do.
men that has like a family history of some type of cancer. It doesn't have to be breast cancer.
Male breast cancer is typically genetically mediated. So that is one of the national guidelines for genetic testing and screening. All cancer history is not equivalent. If you have a family history that's full of lung cancer and skin cancer that's sun mediated, it's not equivalent. We look at specific types of cancers that come in groupings on genes: breast, ovarian, prostate, depending on age of diagnosis, colon, pancreatic, gastric, melanomas, lymphomas, leukemias, angiosarcomas. So family history is important because it's not just cancer, it's type of cancer, it's age that those cancers were diagnosed, and it's also how many people in the family were affected, if that's known, versus how many were unaffected. If you came from a family where you had 16 children and 12 of your siblings had breast cancer, colon cancer, ovarian cancer, pancreatic cancer, that ratio is significant. Versus if you came from a family with 16 children and one person had breast cancer and two brothers had prostate cancer in their late 70s. That's not as significant.
All right. So the holidays are coming up. Families are getting together. Would you guys say that this is the best time to talk about family history? At the table? Maybe?
Absolutely, if you can. Even if it's not at the table, in the corner, in the kitchen, cooking.
We're gonna have to start somewhere, because I mean, this is something that I can say that African Americans, they do not talk about. Right. This is a hush hush thing, and we're gonna have to start getting this information out.
Yes.
And as we're asking questions, I mean, we're doing our screenings with our patients, and we're asking, do you have a family history? I mean, the holidays are coming. I definitely am encouraging my patients to bring up the conversation at dinner table. You know, as you're watching a football game, maybe not at the football game, but maybe during a commercial, asking, did cousin Ed, you know, does he have prostate cancer? Or did Uncle Tom or somebody have prostate? Did Aunt Betty have breast cancer or something like that? These are things that we need to start bringing some type of awareness to, and not, as you said, taking it to the grave.
I don't like those conversations at the table, because holidays can be fraught, because who brought the pie, Who bought the potato salad? This person's mac and cheese is booty. So they can be a little bit fraught. But I do like the idea of having those conversations when you're cooking, when you're playing card games. You can't get men to focus on nothing but the game when the game is on. So you got to catch them when there's a whole lot of talking going on.
No.
And being willing to kind of ask the questions before we forget, because as we get older, we do forget some things too. When it's been a while, or we don't have that history, or it didn't happen to us, sometimes the details get a little bit fuzzy, you know. So I would say, you know, anywhere where you're kind of gathered when emotions and tensions are not high is good. Shay, I want to bring up something a little bit controversial because I really want your opinion on this.
Absolutely.
So, you know, one of the things that I find treating my patients and that I struggle with as a woman who is perimenopausal, I might be menopausal for all I know, I haven't had my hormones checked, but one of the things that we find as we get older is that weight management and weight control becomes very, very difficult. And one thing that as physicians, we do a lot that can be very discouraging to our patients is they come in and we see their BMI is not ideal, is to give them a you need to lose weight lecture. And if they've been trying and working hard at these lifestyle measures, they are so discouraged when they walk out like, I've been trying so hard and all he told me is that I need to lose 20 pounds. Well, one of the hardest things to do when you're receiving a cancer treatment, especially a breast cancer treatment, which sometimes we are giving you medications that impact your hormonal balance, it is damn near impossible to lose weight on those medicines for many women. So I tell my patients, well, let's look at other endpoints of health. Let's look at your blood pressure, your blood sugar, your heart rate, your lipid profile, and get those things in order. Even if your BMI or your weight is not dropping the way that you want it to, let's look at other determinants of health. Are you exercising? Do you feel strong? Does your body do what it's supposed to do? But now that I'm here with somebody who is a nutritionist and specializes in plant-based science and nutrition, I'm a little bit worried, like, ooh, she might yell at me.
Well, because that is an excellent question, and then that was an excellent
segue
example of how you put everything together. And as you were talking, I was just thinking of how I'm going to answer you and answer. I never tell anyone you need to lose weight. I always tell them, let's focus on those important numbers. Okay. Your BMI, it lies. Okay. Because my BMI is high and everyone knows that I'm the poster child for better health. Okay. Let's focus on getting your hemoglobin A1C controlled. Let's focus on getting your cholesterol numbers controlled. What about your blood pressure? Don't you want to get off your medication? Let's focus on getting you excited about getting your health back together. Weight loss will be an added on bonus is what I'll tell them, okay? But let's focus on getting you off your medication. But the weight loss will be an added on bonus. But let's get some money back in your pocket and get you off your medication. Okay. And this is how we're going to do this. All right. And I have a little program that I have for my patients, of course, plant-based. And I put them on a 30-day trial. And this is what I do with my patients, all of them. All right. And it works. My 30-day trial, it works. And I'm like, well, you know, if you want to do it again for another 30 days, let's just see what happens. And we'll draw labs. And then we'll see where your hemoglobin A1C is, your cholesterol. And let's just see how the blood pressure looks in 30 days. Blood pressure is coming down. Hemoglobin A1C is coming down. Cholesterol in 3 months is coming down. And guess what? The weight loss. Guess what? That's just an added on bonus. That's coming down too. So we don't focus so much on the weight. We focus on those other numbers.
Okay. That's good.
That's why my patients love me.
Yes, we do.
That's right, Alice. Alice know about those important numbers.
I do. Yes.
That is
and they definitely work.
Thank you, Alice.
Yes. I am a witness.
Thank you. We focus on those other numbers that matters. We focus on getting you healthy on the inside out. And that is my focus with my patients. I am a stickler on better health. I am a stickler on promoting quality of life. My question is, you are never going to see those younger years. My question is, what is going to be your quality of life in 20, 30 years from now? That's my focus, your quality of life when you get older.
Yes.
And that is my whole focus with my patients, your quality of life. And that's what I try to embed in their heads. Let's work on your quality of life. The weight loss will be an added bonus. That's the bonus.
I love it.
But I'm working on your quality of life. So if you're willing to work with me, I don't work for you. We work together.
Yeah.
That's why my patients love me.
I like that.
Yes, we do.
So there's your answer, Dr. Leonard.
I think better because, you know, I think that I agree with your philosophy 100%, but I don't think that we do a good enough job on the MD side of things to have adopted that and the importance of that, as opposed to looking at these charts and saying that every patient who has this BMI is unhealthy and overweight, and every patient who has this BMI is healthy and they're on the right track. I think we put the focus on the wrong things.
The reason why is because we only get an hour of nutrition. We don't know much about that.
Right.
And that's why I went to school to become a plant-based nutritionist, because I needed to know everything there was to know. And I surround my whole practice around healing the body through exercise and a proper diet, proper lifestyle. Lifestyle change is what I try and teach my patients. And I start them off with a 30-day lifestyle change and see how well they do. And then I push them a little bit further. Let's see how we do for another 30 days and another 30 days. By that 90 days, I have transformed. Isn't that right, Alice?
Yes, that is correct.
Minds to think, maybe I shouldn't have that, because I know if I have that, my cholesterol level is going to go up. God, I can't have that because that's going to mess with my hemoglobin A1C. And I worked so hard to get it down. Jeez, I can't have that. That's going to bump my blood pressure. I work with them. It's all about education. Education is like the key to everything that you can make successful. Education. And I feel that by me educating my patients, my clients, I can get further with them than just giving them medication. I was just telling my patients yesterday, today, day before, I told them your blood pressure is sky high. Well, I need more medication. I'm like, all right, bet. Here's a prime example. I'm going to take a knife. This is my knife. And I just cut your arm and you're gushing out blood. You said, Doc, give me a Band-Aid. Okay, here you go. Here's your Band-Aid. All right, there it is. There's your Band-Aid. Boom, I just put a little Band-Aid there. Oh, Doc, that's not going to take care of the cut. And neither will the blood pressure with that little faulty diet you have.
Yes.
And that's what I'm doing. I'm giving you medication to take care of a faulty diet that you're having. I said, I need your help to take care of your blood pressure. Me giving you medication is going to put you in the PO house, not the poorhouse, the PO house. Okay? It's going to give you side effects that you don't want. Then I'm going to have to give you more medication to take care of the side effects, number 2. Yep. And you're still going to have the high blood pressure. So what I'm doing is prolonging the inevitable, which is a stroke and a heart attack.
Yeah.
So which one do you want? You have a choice. Pick which one.
Very
so you can work with me to get you off the medicine and give you better quality of life, or I can work for you and keep giving you pills, and then you come in and I'll give you more pills. I mean, which one? It doesn't matter to me. Either I work for you or you work with me. I give patients choices.
I like that.
Absolutely.
All right.
They rather work with me.
Absolutely.
Yes.
Absolutely.
All right.
This is why we need representation in the office.
Well,
because you can come at us like that, but I'm gonna tell you, if I'm sitting in the office with somebody who don't look like me and she comes at me that way, I'll be like, wait a minute.
Well, it's really easy for me to talk to people that look like me because they look at me and I don't talk. Well, I am professional, but when I'm sitting across from my own, I can really talk to them. And they appreciate that I talk to them. I even say, look, bruh, this is what's going on. And they love when especially the dudes. I'm like, look, bruh, this is what's going on. Either you're going to do this or you're not. And he was like, Dr. Brown, you are just too much. And They love when I talk to them. I
Yeah.
even threaten some of them. All right.
Yeah.
I'll let them know if you come in here and your blood pressure is still the same, there's going to be furniture moving when you come back in here. I'm not even playing with y'all. All right. And they work so hard. My patients, they work so hard. I mean, they watch, they eat, they write things down, they take their blood pressure, they come back. Doc, this is what my blood pressure was before I take my medication. And they know I'm a stickler about what your blood pressure is before you take your medication. They comply, they do what they're supposed to do. They're excited to come and see me. My patients love me. When I say my patients love me, they love, and I love them. I do. And they appreciate that someone cares about them. I tell them, don't make me care more about you than you do about yourself. Prime example, yesterday, a Hispanic lady did not speak English at all. I'm on the phone with an interpreter, and I told her, this is what I'm going to do for you. And I'm giving her an injection called Manjaro. She's overweight. And I told her, this is going to help get your diabetes down, and it's going to help to get your weight down. And I said, I'm going to put you on this. I said, your insurance might not cover this, but I'm going to prior authorize this for you. I said, you know why I'm doing this? And she said, no. I said, because you're important. And then the guy, he was translating it for me, and she started crying. And then she told him in Spanish why she was crying. And then the guy translated back to me, and he told me, he said, in her family, no one says I love you. No one says you're important. No one says that. And she said that, and you said that to her. And she said, thank you.
That makes a difference.
No one says that to her. She said, but she said, thank you. And she really appreciates you for saying that to her. And I told her again, she is important. And I said, every patient that sit across from me, I don't care what color you are, what nationality you are important. And I said, and if you can't convince yourself that you're important, there's no way that you can convince anyone else that you are important. And I said, every prescription that I give to every patient, I write on there that you are important. I said, you put this on your mirror in your bathroom, and as you're brushing your teeth, you say that to yourself every day. And she took the prescription.
See, that's what it's about. It's about what we do in the community and how we approach our patients, the love that we have. And with the four of us today, including Alice, we did it.
Yay.
We did it.
I agree.
So this is what I do with my patients, Dr. Leonard. I threaten them and I love them at the same time.
There you go. There you go.
Absolutely.
All right.
So we are out of time. We are going to let Alice give the last words, but I will give the very, very last words. Being that Alice, you did come on the show last, and we do want you to just give like maybe some words of encouragement for those women out there that might be going through breast cancer that may not have that outlet. We want to give you those last words to maybe give some words of encouragement to those women out there.
Well, I just say, stay strong. Don't let anything, is this too shall pass. This will be a testimony for you. Although you can't see the light right now, you will see the light. And this will be a testimony. Don't make it all about you, because it's about you sharing your story to help someone else. And that's the most important thing. Don't wallow in it. Don't make it about you. We're all human. We have moments, but get up and think how this is going to help somebody else.
Absolutely, absolutely. And also, I wanted to let everyone know that we are doing a segment for the month of December. It is called Opening Up a New You for Christmas, okay? I am doing a segment to where I am taking 20 people, whether you are in the state of Maryland or in another state. I want 20 people that want to do a full transformation of their own health, that need help starting a new lifestyle change. If you need help trying to figure out better eating habits, if you need help with weight loss, if you need help with exercise, if you need help with a coach, if you need help with someone putting their foot knee deep, that would be me. Okay. If you need that help, okay, I am doing a opening up a new me for the month of December. The whole month of December will be me broadcasting patients, which I will be having my patients from my own practice and the show here. They will be opening up a new them. We've been having some major weight loss with my patients, and they are very excited to come on the show. But we are taking on 20 new people that would like to be a part of my challenge. So I'm going to put on here my contact information for anyone that would like to be a part of my I'm sorry, I'm just trying to get some stuff off of here. Give me 1 second, guys. That would like to be a part of my opening up a new me for the holidays. If you need help with anything, changing your lifestyle, if you want to be a part of that, please, 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 my information is down there at the bottom. For a free consultation, just go to sbbfitforlife.org, or you call my number, which is 443-470-9140. It's down at the bottom of the screen. If anyone would like to be a part of my podcast for the month of December, it is called Opening Up a New Me for the month of December. We will be doing that all month for the December. I'm very excited. We are also doing a 20% off for all of my services, okay? All of my detox systems, my detox soups, my detox teas, my detox juices, everything is 20% off, okay? But you also have to be a part of the Opening Up a New Me for the month of December, okay? So all of that will be 20% off. My consultation, well, the program itself will be 20% off. So if you are interested, please set yourself up for a free consultation. I would love to talk with you. We are all about improving that quality of life. And we're not trying to wait until the new year. You know how you guys like to do. Well, I want to wait until the new year because that's when I want to get started. No, I'm not waiting until the new year, guys. I want to get started before the New Year's, okay? So if you guys are interested, please, my information is down at the bottom of the screen. If you guys are interested in connecting with Rhonda Silva for the
any information.
For any information, I'm going to put the information back up here for this for the what is that, Living and Loving Life Support Circle, English and in Spanish. The numbers here on the screen. Thank you so much, Dr. Leonard. Thank you so much, Alice. Thank you so much, Rhonda Silva, for being a part of My Health Matters. You just don't know how much this means to me. I tell everyone we only get 15 minutes to be able to educate our patients. Me and Dr. Leonard, but we definitely appreciate you guys giving our community 1 full hour about breast cancer and breast cancer awareness. We do appreciate you for that. So God bless you. And we ask that you just hang out just for a couple of more minutes after the show. Thank you guys for chiming into My Health Matters. And we look for you again next week for another edition of My Health Matters. God bless.
God bless.